Yeah, my coverage plan is slightly imperfect, but I think it's fine. Yes.
Okay, if anything comes up, let us know.
Yeah.
All right, sorry everyone. Thank you all for joining us today. Uh, Apologize 1 second. You're good, Dr. Ferguson? Okay, so apologies. They're calling some codes at the hospital, and Dr. Ferguson is an active physician. So just making sure that there is nowhere else that she needs to be. But fortunately, she's here with us right now. So thank you, everyone. Appreciate you joining us for another episode of the group chat. Today's topic will be birth control and family planning. As Dr. Ferguson gives her presentation, you're welcome to submit questions in the Q&A portion of the Zoom. They'll go to me, and then our speaker will answer them at the end of today's presentation. This presentation is being recorded, however, no attendees will be identified. And as a reminder, the information shared during this presentation is not medical advice, but we will be providing additional resources at the end of today's talk. So with us today, we have Dr. Grace Ferguson. Dr. Ferguson provides general OBGYN care, and her special interests include family planning services, pregnancy loss care, and managing birth control for women with complex medical problems. She currently practices at AHN's West Penn OBGYN multi-specialty practice. She has immense knowledge on today's topic, and so without further ado, I'll pass it over to Dr. Ferguson.
Thank you. Let's see. You got that, Bree? This is all good?
Good to go.
Okay, so first we're just going to spend one moment talking about the legal history of contraception, because we may all be aware that sometimes medical care and politics play together in our environment. And so really interestingly, in 1873, the Comstock Law was in place. This was a time when there was a lot of speak of sort of like decency in public, and it banned the mailing of anything that was indecent. And so right now in the news, you'll sometimes see people invoke the Comstock Law, and they talk about how that could come into play in future laws surrounding birth control, prescription of birth control, and whether or not you can mail anything from a reproductive health standpoint. In 1916, Margaret Sanger, who is the creator of Planned Parenthood, opened her first birth control clinic. Slightly later in life, she created Planned Parenthood. In 1965, this is a Supreme Court decision called Griswold versus Connecticut. And in 1965, the Supreme Court said that we have a constitutional right for married people to receive contraception. In 1972, so 7 years later, this case, Eisenstadt versus Baird, gave the right for unmarried people to access contraception. In 1973 is the famous Roe v. Wade, which allowed a constitutional right to abortion under the right of privacy in the United States. And then in 2021, we reversed Roe v. Wade, and now the right to abortion is down to each state. And so why is the topic of contraception and family planning important? Well, there are 62 million women in the US that are childbearing age, which is 15 to 44 approximately. Obviously, there are people who are less than 15 and over 44 who sometimes become pregnant. And over 99% of these people who have ever had sex have used some sort of contraception in their lifetime. The average American woman wants 2 children, which means that she's contracepting or preventing pregnancy for around 3 decades of her life. Couples not using contraception have an 85% chance of conceiving over 1 year of unprotected sex. And so there are about 6.7 million pregnancies in the US a year. Just about half of those are planned, and the other half are unplanned. Of the unplanned pregnancies, half of those continue on to childbirth, and the other half of those end either in abortion or miscarriage. So today, we are going to talk about birth control because it is so relevant to so many women for so much of their lives. There are so many ways of talking about birth control, and how you talk about it kind of has to do with your own priorities, and how your doctor talks about it also has to do with sort of where they're coming from. But we can talk about it in terms of, do they have hormones or not have hormones? If they do have hormones, what kind of hormones? We can prioritize and discuss them in terms of how effective they are. So how good are they at preventing you from getting pregnant? We can also talk about them based on how long they work for. Is it something you use every single time you have sex? Is it something you engage with once a day? Is it something that you only have to deal with once every 5 years? Or is it something like getting your tubes tied where you have it and then you're good forever? And then sort of similarly is the frequency of engagement. So how long it lasts for and how often you have to use it are both are pretty related to each other. In the US, Most people who are contracepting have either gotten their tubes tied or use pills. So sterilization for women, this does not include a vasectomy, is in blue, that big 37% bar. The next most common one is birth control pills, which is that hot pink bar at 28%. And then you can see after that, the next most common is male condoms. And then everything else is kind of like around 5%. Uh, I think as a whole, IUDs and implants, these long acting reversible contraceptives, are slowly increasing in interest. And there are more people interested given the last couple of years of politics involving reproductive health. And then sort of the interest in depot, patch, ring, and other methods are relatively stable. There are a lot of different reasons and factors influencing how someone chooses to engage or not engage with birth control. And so I think especially in this setting where we're having this community discussion, there's a lot on social media, there's a lot on television and books and news. So there's a lot of external influences on what you know and what you think about birth control, whether or not you received any formal education as part of your schooling, can certainly impact what you know about birth control and how you feel about it. Your cultural and personal attitudes, different communities, different religious faiths, different families, and what has happened in your family and who's had experience with what can certainly influence how you feel. People from with heritage and different backgrounds certainly have different opinions about different types of birth control. Your own personal situation, if you are married and trying to have children, you will have very different contraceptive priorities than someone who's like 16 and getting their college applications together, whether or not you have an active partner, whether or not you ever want to have an active partner, if you're sexually active with men or women or neither or both, your own personal history of contraceptive use, if you've used something before and it worked really well or it worked really poorly, and whether or not you can access the healthcare system. For a lot of people, having steady insurance that covers birth control, having a provider of birth control that you're comfortable with, being able to get there, taking a bus, being able to maybe make multiple visits if you're trying to get something like an IUD and you need to like talk about it and then schedule it. And then sometimes it's even just, you know, you want to use birth control pills, but it's hard for you to get to your pharmacy to pick up your refills. And so there are a lot of sort of system barriers that we have to consider as well. This is a little bit academic, but I think it's just sort of nice to think about another way people think about whether or not they need birth control is whether or not they feel like they are able to get pregnant. And so when I think when I look at this chart, there's this little arrow coming in. I think you can see my mouse. There's this little arrow coming over here that talks about salience of pregnancy planning. And so this is like, do you think you should use birth control? Do you feel like there's any point to even thinking about when you get pregnant? And the things that feed into that decision are your own feelings about whether or not you think you can get pregnant, whether or not you want to use birth control, like have you had bad experiences before, and what do you think pregnancy will be like? So how do you feel about pregnancy? Can you get pregnant? Do you want to do anything else like birth control? And then sort of outside of that is your own social and economic environment, you know, your social life, whether or not you have a job, what your peers are doing, is everyone around you getting pregnant, is no one around you getting pregnant, how your relationship could be with a potential sexual partner, and how you feel about accessing the healthcare system, right? Do you have a doctor? Do you not have a doctor? Are you in a state that allows abortion? There's a lot of sort of healthcare system factors. And then it comes down to sort of how you feel about it on the inside. Do you want to get pregnant? What feelings do you have about pregnancy? Are they positive? Are they negative? And then are you actually interested in this time, or are you maybe interested in the future, or are you maybe never interested? And you kind of take all of those factors in, and that kind of plays into whether or not you feel like whether or not you should contracept. So for some people who do not want to get pregnant, they have good access to healthcare, but they think, you know, maybe I'll get pregnant later. It makes a lot of sense. Then they're like, yes, I'll get an IUD. But for other people who feel like, you know, maybe their doctor told them they can't get pregnant because they had an infection earlier, and then it's really hard for them to get birth control because they don't have insurance, and their life is just a little chaotic, and maybe they're like, you know, I can barely figure out what I'm doing tomorrow. How am I supposed to plan for the next 5 years of my life? if they're not in a planning state of mind, they may not feel like they need to use birth control. And they're not in a place to sort of prepare for pregnancy, right? They're just trying to get by day to day, and that could result in really different behaviors about birth control. So now that we've acknowledged that everybody's kind of coming at this decision making from a really different place, I'm going to use this framework to kind of talk about birth control in general. So this framework comes from the University of San Francisco, very medically and scientifically accurate. It kind of categorizes by multiple ways that I think is really helpful visually. So when you look at the top orange bar, the 5 stars really, really well. So these are methods that are very good at stopping you from being pregnant. 99% plus efficacy at preventing pregnancy. They are also long acting. So you can see sort of that lower bar, 3 years, 3 years, 5 years, 12 years, forever. The next line down in the green, pretty good at keeping you from getting pregnant. When you look over at the 6 to 9 women in 100, that is still over 90% effective. And they're very different in how often you have to engage. So every day, every week, every month, every 3 months. And then when you go down to the last bar, it gives it 1 star. It lists 12 to 24 in 100 women, which is somewhere between kind of like the high 80s to the mid 70s, like 75 to 88% effective, which is still better than nothing, because when you think about not using any birth control, your likelihood of getting pregnant is 85%. So this kind of flips that statistic on its side. So even though you may feel like, oh, they gave it 1 star, it doesn't work so well, it actually still makes a big difference compared to not using anything for contraception. And here we're talking about male withdrawal, using a diaphragm, which is something you use every single time you have sex, tracking your cycles on a calendar and timing intercourse, or condoms, either internal or external. The benefit, of course, of condoms is also that you get sexually transmitted disease prevention as well. And so this is the big framework, and then we're going to go into each method individually. There's so much to know about all of this, and so again, this is not medical advice for anyone individually, but I'm going to try to just sort of give you highlights and keep on moving, and we can talk about questions at the end. So male sterilization, vasectomy, works by disconnecting the tubes that carry sperm so that they just can't get out. There are no contraindications, which means there's no reason why you couldn't do it. And how do you do it? This is the big thing. I would guess a lot of people attending this current talk are women. And so the big struggle is that it's not you, like someone else has to do it. So the person getting the vasectomy would schedule an appointment with a urologist. Often these are the doctors that also manage kidney stones. They're sort of like bladder doctors, and they also manage male organs. So urologists, typically will have a pre-op visit where they discuss the procedure. They'll come back and do the procedure. Sometimes it's done in the office setting. So you like go in, it happens and you leave and you're awake, there's no sedation. Sometimes it'll happen in an operating room and you might have to come in kind of early, don't eat the night before, have same day surgery and go home later. And then really they need to come back to the office to provide a sample and make sure that the tubes are really blocked and that when they ejaculate, there's no sperm in there. And once you have that confirmation testing, then you're really good to go. But the confirmation testing has to have a 3-month wait. And so even though it's really easy to say, oh, my partner's getting a vasectomy, it actually requires quite a bit of legwork and a couple of months for that to become true. The other good thing about vasectomy is it's actually reversible much of the time, so 60 to 70% of the time, which is very different from female sterilization. So female sterilization, we'll often call this getting your tubes tied. That's a little bit of an old saying. Now more than anything, we've removed tubes, so we're not tying anything, they're just coming out. When you remove the tubes in a woman, it prevents sperm and egg from meeting each other. And so your fallopian tubes are how the eggs get into your uterus so that the sperm can meet them. You can do it in a couple different ways. So if you're a non-pregnant person who just wants their tubes out, you just go to your gynae and we talk about it as a surgery and we schedule it anytime. We call this an interval tubal. Or you can get it immediately postpartum. This one is a little bit tricky, but if you come in and you have a delivery, you can either, if you're having a C-section, it's really easy and we can just remove your tubes at the time of your C-section because you're there. Or if you have a vaginal delivery and you have an epidural, immediately after delivery, we can bring you to the operating room and using the epidural you already have in place, make a small incision and remove your tubes. That one's tricky because for anyone who's ever had a baby, you may know that labor and delivery is a very chaotic place, and sometimes everyone's having an emergency C-section at once and there's no time to get someone back for their tubal. And so when we talk to you about if that's your plan, we always like to make sure you have a plan B, which could just be, I'll come back in 3 months and get my tubal. The other thing about sterilization or getting your tubes removed is that if you have Medicaid insurance, you have to be at least 21 and you have to sign this paperwork at least 30 days before the date of your surgery, and you have to get it done within 180 days. And this is because not so long ago, doctors would judge patients and say that you, because you are poor or Black or young, shouldn't have any more children, and they would just do it. And so this paperwork now is kind of an obstacle, but its intention is to make sure that patients are counseled in advance, they understand what it means, and that nobody is rushing someone into this procedure. The failure rate is really quite low, and it's probably even lower now that we remove the whole tube. The statistics that we have are really from when we were putting clips on it and doing more of the tube tying procedures. But it's not reversible. Even when we did the tubal tying procedures, it was just a little bit reversible and not covered by insurance. And now that the tubes are primarily coming out, it's really quite irreversible. And all you can do if you choose to use your uterus for pregnancy after you've had your tubes removed is you can do IVF, which for many people is not covered by insurance. We switched to taking your tubes out because it significantly decreases your chance of ovarian cancer later in life, and it's more effective as contraception. And so for people who are sure that they never want to have babies again, it makes a lot of sense to also almost eliminate your risk of ovarian cancer. So that's self-injectomy. Really the biggest thing to consider with surgical sterilization is that we worry, one, if you're a bad surgery candidate, like you have unhealthy heart, unhealthy lungs, you've had a lot of surgeries before, we will certainly talk to you about whether or not having more surgery is the right choice for you. But the other thing that we really want to make sure is that when you choose to have your tubes removed, that you are sure that you never ever want to have babies again in your uterus naturally. Overall, the trend is that women who are younger are more likely to regret having their tubes tied. And so if you're 20 coming to us and telling us that you never ever want to have children, we believe you, but we are going to ask you many times that if you are sure. And there are certainly different providers and practices around the country where they may not offer tubal ligation or tubal removal to women of a certain age. And that is really art of medicine and not legal laws or anything. But you can do it. We just really worry because there are many methods that are reversible, and this is truly not reversible. Okay, so another option that is very effective is an IUD. I think the biggest misconception or confusion about an IUD is where it goes. And so in this picture, I want to make sure everybody understands the IUD goes in the uterus, which is where if you were pregnant, a baby would go. When you use tampons, tampons go in the vagina. So that's sort of the most bottom tube in this picture, the bottom part. When you have sex, penis is in the vagina. And so the IUD is truly in a different part of the body than where you have sex. And it's in your uterus in a way where it just stays still, like it doesn't float away, it's not wandering around, it's just kind of hanging out. We will talk a little bit about IUDs. Sometimes they can get malpositioned and rotate a little bit, but the movement is really very small. And if a partner ever complains about an IUD, what they're typically feeling is the string. And so the IUDs do have strings that go into the vagina that hang out at the very top, so that later on, if you want it removed, it's very easy to remove. And also some people will check their own IUD strings, and that's accessible because it's in your vagina. But you can't touch your IUD because that's in your uterus. So the Mirena is the most common IUD people use. I have a Mirena. I've had 3 Mirenas. It has one hormone, a progesterone. It's FDA approved for 8 years of use. And now that we're kind of talking about hormonal methods, you'll see that a lot of the hormonal methods work the same way because they're the same hormones. So it makes your cervical mucus thick, and that makes it harder for sperm to get in your uterus. This does not really translate into the discharge that you feel. It's something that's happening like really high up in your vagina, like at the cervix. It does make the lining of your endometrium, the lining of your uterus, thinner. And so that is why many hormonal birth controls make your periods lighter, because there's just less to come out in a period. And then for the IUD, some people will stop ovulating, so they'll stop having their own cycles. Some people will continue to have their own cycles, and that's because the IUD's hormones are mostly acting in the uterus. And for people who are very sensitive to hormones, there's a very low blood level of the hormone. And if you're very sensitive, your body may see it and just stop cycling. And for other people, your body sees it, but it's not enough to tell it to stop cycling. So you'll continue to sort of have, you may have a little bit of mood change, you may have a little bit of breast tenderness, and will continue to feel that in the background. There are very few contraindications, so very few reasons you cannot have an IUD. If your uterus is a very strange and uncommon shape, if you actively have an STD or an infection, or if you've had breast cancer, you should not use an IUD. And it's very effective, over 99%. We touched a little bit about it, so there are some risks. They're typically very rare. If you have the IUD placed incorrectly, which could be because maybe your uterus is an abnormal size or shape, maybe your provider is not very experienced, but the time of placement can go wrong. And if that is the case, it could end up not in your uterus, and you may need surgery to get it out. That is very rare, but it does happen sometimes, and you should always talk to your doctor about these risks and benefits. Sometimes it gets expelled, which means that your body just pushes it out. And that most often happens when people have really heavy menstrual periods, and sometimes it just comes out in the wave, you know? You may get some irregular bleeding, especially at the very beginning while your body gets used to this. We typically tell people to give it a couple of months and see how it goes. And then another disadvantage is that you really need an appointment to get it inserted. It's not something that you can just start on your own. But things that are really great about Mirena IUDs are that they're very long acting, 8 years, very effective. As soon as you take it out, you get pregnant in the next cycle, and they're fine to use for breastfeeding. They also decrease your menstrual blood loss. So when you actually measure how much blood comes out of your body in every period, it decreases that amount of blood by 90%. And 25% of people will actually just stop having periods at the end of the first year. It does improve endometriosis and bad periods for people. Because that cervical mucus thickens up, it actually decreases your risk of infection in your uterus. And then for people who are perimenopausal or even menopausal, it can help reduce some of those menopausal symptoms. And depending on your medical situation, it may be helpful even after menopause as a cancer prevention tool in the uterus. So Skyla this is really branding, is very similar to the Mirena. It has a slightly smaller tube and it has less hormone. So it's only approved for 3 years of use. In the branding, they're really suggesting that people who've never had children and are younger should use this IUD. Everyone and anyone can get a Mirena at any time. You do not have to have had children first. And I think that people who really, when I talk to people about IUDs, if you want to continue to have a regular monthly period, this is a great choice because the hormone level is small enough that your period will be lighter, but you will almost definitely still have a regular cycle. And if you are definitely not interested in having longer use birth control, then if you want periods at 3 years sounds good, then this might be the right choice for you. Kyleena is another really a branding IUD. So this one has more hormones than the Skyla, it has less than the Mirena, but it's good for 5 years. So if you want to have a regular monthly period and 5 years sounds good to you, then this could be your best bet. Liletta is the generic version of the Mirena, so exactly the same. It is also getting its approval, so it is it's the same product, but it's only approved for 6 years so far, but we know that it's good for 8 years and probably even longer. And the studies are actually still ongoing just for extended use of both Liletta and Mirena. There is also a non-hormonal IUD. It's called the Paragard. There's copper on the actual IUD, and the copper tells your body to kill the sperm. Essentially, it just uses your own immune system against the sperm. Because it has that sort of inflammatory immune response, most people who have a copper IUD have more bleeding and cramping when they have their periods. But if you would like up to 12 years of birth control, that's incredibly effective. and you have reasonable periods to start, this is a great option. A lot of people who don't want to use hormones have a really great experience with Paragard. The other thing about Paragard is that you can use it as emergency contraception. So if you've had unprotected sex in the last 5 days, you can just come in the office and we can place the Paragard, and that will prevent you from getting pregnant. And then some common myths about IUDs. IUDs do not cause abortions. When you use it as emergency contraception, it prevents the pregnancy from sticking. But you are not yet pregnant when it works that way. It doesn't cause ectopic pregnancies. But the thing is, because IUDs are so effective at preventing pregnancy in the uterus, if you were for some reason to have a sperm meet an egg, it would not be able to get in the uterus. And so you're very unlikely to get pregnant, but if you do, it is more likely to be ectopic. This is a really fine detail. I would not worry about it, but it does not cause ectopic pregnancies. It does not cause infections. It does not impact your future fertility. It can certainly be used by women who have not had pregnancies before. And then if you have an infection, you also don't have to take out the IUD. It actually mostly helps you, and very rarely does the IUD have to come out if you're having an infection. So not an IUD, still very effective. There's one implant that goes in the arm for birth control. It's called the Nexplanon. That little picture shows it's a very small, skinny silicone rod. It's very similar to what was the Implanon, which was, I think it's been like 10 years since they switched the branding. It has the same hormone as the Mirena progesterone. This one, it works by inhibiting ovulation. So this one puts the progesterone blood level in your blood. Your body sees it and you don't cycle. So it inhibits ovulation. It has a very low level, just enough to inhibit ovulation, and it is very steady, which is a real bonus for some people who don't like their hormones to go up and down as much. Like if you take pills every day, it goes up and it goes down. You take a new pill, it goes up and it goes down. This one, once it's in and it kind of settles in a couple weeks, you get this very steady, constant rate of hormones. The FDA has approved it for 3 years. We have great data that says it's good for at least 5 years. And the biggest side effect for this is that you can have sort of irregular bleeding. So people have the same number of days of bleeding as if they were having periods, but it's just sort of more on and off. That does not happen to most people. It only happens to about 10% of people who use this. But we do like to let you know, like, this is the thing that could be most annoying if it happens. It probably will not. This, I think, is also really popular amongst sort of younger patients who are a little more intimidated by a pelvic exam for an IUD insert, but they still want something really effective and long lasting. And the big important thing about all of those methods, the IUD and the implant, is that you can always get it out. It is the whole point is that it's reversible. And so if you think you want to try it, but you're a little intimidated, there's nothing to lose by trying it. And if you don't like it, we will just take it out. You don't have to prove yourself. You don't have to have like some great reason. If you want it out, it can come out. So we're now going to talk about that second level. So it's still quite effective, but not as effective as those IUDs, implants, and tubules and vasectomies. Pills, very, very common. When we think about pills, they can either have 2 hormones or 1 hormone. If it's 2 hormones, it's estrogen and progesterone. If it's 1, it's just progesterone. They work by inhibiting ovulation, so stopping your cycling. There are many, many different types of estrogen, types of progesterone. You can have a little more of this, a little bit of that. So you will notice that there's tons of brand names for pills. And they tend to work kind of in like the 92%, 93% efficacy. There are some reasons why you should not use birth control pills with estrogen. So this is the combined oral contraceptives, 2 hormones. If you have a blood clotting disorder, so these are blood clots that are in your brain, in your lung, in your legs, not the blood clots that come out of your vagina when you have periods. If you have migraines, so really bad headaches that come with aura, and aura is when you sort of see spots in your headaches. If you're a smoker over 35, you have blood pressure that's not controlled, you've ever had a stroke, a heart attack, breast cancer, significant liver disease, if you had a certain kind of gastric bypass, and there are very specific medications where the medication will make your birth control less effective. And that's mostly, we're talking about medications that treat hepatitis C or HIV. Some seizure medications also can do this. So whenever you start birth control, we will always review your medical history. The great thing about pills is that they're totally patient controlled. You choose what time of day to take them. If you don't want to take them, you can stop right away. And then they also have a bunch of great benefits. Many people who are on the pill really, really love their pills. They tend to make periods lighter, less painful. It improves endometriosis. It can improve acne. A lot of dermatologists will recommend that you start the birth control pill with estrogen for acne, and hirsutism is facial hair. It'll also improve that. It does decrease your risk of ovarian cancer and endometrial cancer by stopping your cycles. Typically improves your cholesterol. And then we talked about sort of improving your menstrual cycles. The mini pill is the birth control pill with just one hormone. It's norethindrone. There are now more than one formula, but it's a little bit less commonly covered by insurance. So you're mostly seeing this same one pill, norethindrone. It doesn't have sugar pills in it, so you tend to just continuously take it and not have periods. It works by inhibiting ovulation, same efficacy as the combined pill. We often will give it to people when they're postpartum, because when you're immediately postpartum, your blood clot risk goes up a little bit. And so we give you the single hormone pill. And one of the downsides of the single hormone pill is that you really need to take it at the same time every day. A normal birth control pill, you have, like 6 hours of, so if you forget, you could take it when you get home. But when you are on the single hormone pill, the mini pill, you really need to try to take it within the same hour. Next is, so in this second row of medium effectiveness options, you can get a patch. The patch is a beige colored square sticker that you use once a week. And then if you want to have a period week, you leave it off for 1 week, have your period, and stick it on the next week. It works just like the pill and is very similar in its effectiveness like the pill. And the one important thing about the patch is if you're over 198 pounds, it will be slightly less effective. We can't tell you exactly how much less effective, probably somewhere in the 80s. And so certainly still much more effective than using nothing, but you have to kind of look at your own goals. Like, is it really important to me to get as high of effective percentage as possible? Or is it more important to me that I think the patch is a really convenient way that I can remember to use? The vaginal ring, the brand name is NuvaRing. That is something you use once a month. So you put one ring in, leave it in your vagina for 3 weeks. And if you want to take it out and have a period, you can take it out. If you want, there's enough medicine in the ring to actually last 4 weeks. So you can kind of use them continuously and skip periods. Works like the pill. You can take it out for 3 hours at a time. There really are very few reasons you should take it out. This picture is not actually the NuvaRing. The NuvaRing is skinnier and much smaller. And so people who have intercourse in their vagina just leave the ring in, and it typically just stays in place. This bigger, thicker ring is a newer ring called Anovera, and it's actually a ring that you can use continuously for 1 year. They recommend that you leave it in for 3 weeks, take it out, have a period, and then you can put it in the fridge for that week it's out, and then take it back out and put it back in and use it this way for 1 year. I think it's kind of good if you don't think you can access a pharmacy, if you're maybe like going out of the country or kind of getting out there. But I haven't had many patients actually ask for this because it is like it's a bigger, clunkier ring. And then we talk about blood clot risk, and like there was that list of all the reasons why you should be careful about using birth control pills. But you still have to sort of zoom out and think about the alternatives. And so if you don't take the pill, your baseline blood, you still have like a very small risk of getting a blood clot just as a human being in the world. If you take the pill, it increases that risk. That's that second bar. If you get pregnant, you really increase that risk. And then if you are postpartum, your risk really shoots up. And so the numbers here are number of clots for every 10,000 women per year. It's like a hard number to wrap your head around. But really what's most important, what I want you to know, is that when we talk about increasing your risk of clot, it's compared to doing nothing. But if you also do nothing and you get pregnant, your clot risk really, really shoots up. And so we have to be, when we talk about what we would prefer, it's important to really be realistic about what you're at risk for. Other birth control methods, Depo-Provera, the shot, one hormone, you give it every 3 months, works by inhibiting ovulation. It's quite effective because it's a pretty big dose of that hormone progesterone. And even though we give it every 3 months, it's actually good for a little bit longer than that. So it's okay to be a little bit late for your shot. And because it's kind of flexible in that way, it does work pretty well. A lot of people stop Depo. And so You do get some irregular bleeding sometimes. Depo takes a long time to come back to fertility, and this is really unique to Depo-Provera. So everything else we've talked about so far, if you stop it, the next cycle you will just be regularly ovulating and you try to get pregnant. But because Depo is a shot, some of it stays in your body and it takes months and months for it to wash out. And so you do want to think about, if you're a Depo patient and you're thinking, I want to get pregnant next year, you may want to stop it pretty soon and transition to something like pills. The most common thing people talk about for Depo is weight gain, and I have kind of a wordy slide coming out about that. And then people do sometimes talk about this decrease in your bone density, which the TLDR is that's not really real. But the most important thing is, if you're someone on Depo and you're in your later 40s, is as long as you stop your Depo before you hit menopause, your bones will just go back to totally normal and it will have no effect on your life. So it's very long acting. A lot of people who keep up Depo and continue past their first shot will actually stop having their periods. For people with endometriosis, Depo is a really great option because it does really suppress that cycle and can shut down that endometriosis. And then if you have seizures or sickle cell, it actually can improve those diseases very specifically. It protects your uterus against endometrial cancer. It is fine for breastfeeding. And so it's another shot where, or it's another medication where if you're postpartum or we have you in the hospital and you just need a break for whatever reason you're in the hospital from pregnancy risk, sometimes people will just get one shot of Depo-Provera, so they get 3 months, they can get their lives together, follow up in the office, and then we can talk about what you want to do next. So weight gain is a really common complaint and concern about Depo-Provera, and most of the time there have been multiple trials talking about looking at who gains weight, how much weight is gained, and typically you can kind of summarize it in the way that some people will gain around 5 pounds or less, not all people. And the hard part is people who are using birth control are women who may be gaining weight anyway because you're in your 20s and your 30s and you're entering the workforce, you're in school, there's a lot of reasons why people gain weight. You're stressed, living your life. And then, but what I will say is the people who gained the most weight were Black adolescent women. And so if you're in that group, I think it's much more of a serious conversation. For most people, it's really a matter of like 3 to 5 pounds. But for young Black women, they're much more likely to gain more than 10% of their weight. And so if you're already heavy, Depo may make it harder for you to lose weight and may make you gain weight. And in this situation, again, the conversation becomes like, what are your risks? And how do we balance the risk of weight gain versus the risk of pregnancy? And now we're moving on to that final column, things that you have to use more often or are less effective. So male condoms, I think, are really familiar to people. They have a 15% failure rate. They work by preventing sperm from meeting the egg. You don't need a prescription. They are relatively cheap. There are a lot of places to get them for free, and they have very few side effects. They can break. You have to use them every time. You have to be careful about what kind of lubricant you use. Some people, you may have to go get them, and that can be embarrassing. And you have to stop the action to get it on. And I think maybe the most important disadvantage or risk is that you, as the possible pregnant person, don't have total control over whether or not a condom is put on, used, or put on correctly. And then it can prevent STDs. There are internal condoms or female condoms. Some people do use these for anal sex, so we don't call them, so then anyone with an anus can use them for condoms. Similarly, a barrier, it just goes in the other direction. You should not use both condoms at once because they'll rub against each other and damage each other. And then they are more expensive to buy. They're less common. They're less available for free. They can be noisy just because of how the material is. They can like kind of rub and squeak. And then they can be irritating to the person wearing the condom. They do, for all the other good reasons, like condoms are effective for many ways. They are controlled by the receptive sexual partner. And then you can insert it quite a number of hours, 8 hours before you have sexual activity. And so sometimes that can improve that element of spontaneity. There are diaphragms. This is actually a picture of an older diaphragm, kind of the diaphragm from like the 80s. It is a little bit less effective than condoms. And it works by both a little bit of a barrier, like a little bit of a wall to prevent them from egg and sperm from meeting. but it mostly works by being a holder of spermicide. And spermicide is gel that kills sperm on contact. And so this is the reasons you shouldn't use it if you're allergic to the diaphragm latex. And the only diaphragm on the market now I think is not latex. If you have trouble getting it in, because this is something like a menstrual cup you have to insert in the vagina. If your vagina is abnormal, you have some women will have a little wall in their vagina. If you don't know what I'm talking about, you probably don't have a wall in your vagina. And then if you have a lot of urinary tract infections, sometimes this may make them worse, but that is just something to talk about. I wouldn't say you cannot try it. The diaphragm that is available now is called a Kaya, and that's actually the picture of it. It is same idea. You put spermicidal jelly in the little cup and push this into your vagina. It is made of silicone, so it's not latex. So you'd have to have a silicone allergy to not be able to use it. It's one size fits all. Diaphragms used to have to be sized for your cervix, but this is a one size fits all. And it's a really great option for people who don't want hormonal birth control, who don't want to use male condoms, and can be really great. So definitely a good option for many people. Right now, you need a prescription, but there are a lot of places that you can get an online prescription, and certainly any of us would be happy to prescribe one for you. And the website's really great. So if this is interesting to you, the Kaya website has great videos about how it works, how to use it. It's like a really good new website with great resources. Fertility awareness is also called the rhythm method, the calendar method. If you are into international public health, there's a lot of ways where in low resource settings, they try to make this as teachable as possible. So one of the ways they do that is something called cycle beads, which is like a little bracelet that helps you track your cycle. Very related to this is the idea of taking your basal body temperature and tracking your ovulation. Also related to this is you can do cervical mucus tracking. And so that is every day examining the type of discharge that's coming out of your vagina and seeing how thin or thick it is. If you have an app that tracks your periods and you sort of click the extra buttons, many of these apps will allow you to add this kind of information, your body temperatures, your cervical mucus. And how well it works is so variable because people use different combinations of these elements. And, if you misinterpret your bleeding and it's just a spotting day and it's not actually your period, then the whole thing gets thrown off. So it has a lot to do with how well you know your own body and how good you are at keeping track of your data. But it works by figuring out when you ovulate and then avoiding the time around ovulation for unprotected sex. The other thing about this is that if you do it the other way, this is how people get pregnant. And so if you're trying to get pregnant, you want to know when you're ovulating and you want to have unprotected sex when you're ovulating. And so the menstrual cycle is very complicated and different in many people. But the big picture idea is that for most people, when we talk about cycle days, the first day of your last menstrual period is day 1. And so you'll have your period the first week. The second week, your body is getting ready to ovulate. At the midpoint of most people's cycles, which is around day 14, is when you're likely to ovulate. So you release an egg into the world. And so the 5 days around ovulation are the times you want to avoid or seek, depending on what you're trying to do with pregnancy. And it's 5 days because sperm can live in your body for up to 5 days. And so just because the egg is only out for 1 day, if there's sperm hanging out from a couple days before, or potentially sperm that gets there right after you ovulate, you could get pregnant. And then the final half of your cycle is if you got pregnant, your body is setting it up. And if you don't get pregnant, your body's kind of like resetting everything so that you can try again next month. And then you'll have a period at the end of this 28-day cycle. You should not use calendar tracking if your periods are super irregular, because it's not going to work for you, or if you've recently had childbirth or a miscarriage, because again, your body has to reset and you can't rely on your cycles being accurate. You have to pay a lot of attention. You have to have a cooperative partner. But on the plus side, it is free and it encourages a lot of awareness of yourself, which is really great. Yeah. You can use withdrawal. That is, it also super variable on you and your partner and how well your partner can manage themselves. Could be 80% effective, could be less. And then it is also a little bit of a gamble, a lot of a gamble, because that pre-ejaculatory fluid can also have sperm in it. But it is free, which is great. I think the last method is lactational amenorrhea. That is just to say that when you breastfeed exclusively, so no formula supplementation, the hormonal state of your body suppresses ovulation. So if you are breastfeeding exclusively, your baby is less than 6 months old, you have not yet had a normal period, this is very likely to help you not get pregnant because you're very unlikely to ovulate. This kind of makes sense from an evolutionary standpoint. If you've just had a baby, your body is focused on providing for the newborn at home. And then as the breastfeeding pressure comes off and you feed your baby less and less, your body can start to ovulate again and think about having more babies. This is a whole different topic, but when you are breastfeeding, you can have a lot of vaginal dryness. And so it's really not a side effect of the method, it's just a side effect of breastfeeding. And there are a lot of things we could talk about for breastfeeding. We could do that another day. And the other bonus is that you're breastfeeding, which has a lot of bonuses. Oh, spermicide, Phexxi. Phexxi is kind of new. Phexxi has, I think, an aggressive marketing campaign out there. So it came up in my Hulu ads the other day. It is a spermicide without a diaphragm. And so instead of having like a little cup to hold the gel up by your cervix to meet the sperm and kill them, you just squirt, like you can see it's like a tampon applicator. You squirt the gel in your vagina, and then any sperm that ends up in there gets killed. You have to use it every time you have sex. And then it does not work after. You have to use it in advance. Okay, those are all the methods. Now I just have a few like thoughts on birth control. One is this idea of quick start. And so I think many providers of birth control now use this, which basically means whenever we prescribe your birth control, you should just start it and use a backup method of contraception for 7 days. So maybe, you know, we gave you your pill today, doesn't matter where your cycle is, you should just start it, use condoms, or don't have sex for 7 days, and then you can consider your birth control method effective. The only reason this is important is because back in the day, you would always time your birth control to start with your next period. And the problem was that if you waited for your next period to start your birth control pills, you might actually just get pregnant while you're waiting. And that is really not the point of prescribing birth control. And so we recommend quick start for everyone. And then the other thing is, what happens if I miss my birth control? The big picture is that you should take it as soon as you remember. And if you want to be as conservative as possible, use birth control, like condoms for a week after you miss your pill. If it is like available to you to send us a MyChart message or call your doctor's office, we can give you kind of a more detailed, specific answer to your situation. Like, when did you miss it? When did you take it? How many did you miss? But if I were to say one blanket statement on missed birth control, it is take it as soon as you remember and give yourself a week of backup. And then my final thoughts are on emergency contraception. And so there's a lot of confusion. Emergency contraception prevents sperm by meeting egg by delaying ovulation. So if you were about to ovulate and pop an egg out, this taking emergency contraception tells your body to wait, typically delays it a few days so that hopefully sperm will not meet egg. And so the most common confusion about it is that it causes abortions, and it does not cause abortions. So this is Plan B or Ella. Emergency contraception prevents sperm from meeting egg. If you're already pregnant, it will do nothing to the pregnancy that's already there. And so Plan B and Ella are two options that you can get. You can also use your regular birth control pills and typically take 2 or 3 of your regular birth control pill, and that will also delay your ovulation. And those are websites that where if you go to nottolate.com, you can look up what birth control am I taking, how many pills should I take to make it into an emergency contraceptive. You can always obviously reach out to us and we can help guide you in this process. And then you can also get an IUD placed for emergency contraception. So if you had unprotected sex, you definitely don't want to be pregnant. You want to try to prevent pregnancy as much as possible. And you, by the way, wanted an IUD, might as well get one now. That's a great opportunity. And we understand that obviously that is time sensitive within 5 days of the unprotected sex. And so we will get you in as soon as we can. And so from the same wonderful people at the University of San Francisco, this is a summary of emergency contraception. And then this is a great topic to ask your providers about. The other thing is you can always ask your provider to give you a prescription for emergency contraception just in case. The biggest thing is that you never plan to have unprotected sex. And then if you wait till it happens, then you have to reach us and we have to send you a prescription, and then you have to go pick up your prescription, and the longer you wait, the less effective it becomes. So if you think this is something that might apply to you, or you're going off to school, this could be a great thing just to have one in your house, in your bathroom cabinets. Ella, the middle column, is actually the most effective one. It is just more expensive than Plan B, and so depending on your insurance coverage, you may or may not be able to get Ella. If you are over 195 pounds, Ella is also more effective. But again, it's really an access and cost problem for people. All right, questions?
Thank you. That was great. Do you mind switching to the next slide?
Oh, yes.
Okay. All right. Just in case anyone has to drop, I just want to do a quick plug. Thanks for joining us today. We have our next 3 topics announced, and they're open for registration if you're interested in joining us again. If you'd like to book an appointment with one of our AHN OBGYNs, you can do so by calling 412 doctors or visiting findcare.ahn.org. And if you just want to learn more about the services we offer, feel free to scan that QR code. And so go ahead and submit any questions you have. To start off, how can birth control affect your mental health?
Oh, that's a great question. And so the big answer is everyone is different and mental health is incredibly important. For the most part, the things to consider are, what have you tried before? How did they affect you? Because your experience is always the most important experience. I often talk to people, if their mental health is really changes with your menstrual cycle, right? Like every month you go up and you go down, then the birth control may really help you if we do something that stops ovulation and takes that roller coaster out of your life. And we would probably talk about something that may give you kind of a low and steady state of being, because you just don't need those ups and downs. There are other people who actually don't respond well to estrogen or progesterone. For the most part, it's kind of a progesterone problem. And so if I'm a little bit worried about your mood, but we're also worried about getting pregnant, because having an unplanned pregnancy also really affects your mood, then we might start maybe on the mini pill and try something where you can try the hormone out, see how it makes you feel. If it makes you feel bad, you can just stop it at home and we can talk about other options. But if you tolerate it really well and you're like, okay, the progesterone is fine, my body has seen it before and we're coping with each other, and then maybe we'll talk about, then do you want to do it every 3 months in a shot? Do you want to do an Nexplanon? Do you want to do an IUD, potentially something that's a little bit more of a commitment? But I think when your mental health is on the line, it often makes sense to maybe start a little slower so that you have more control over what you're experiencing.
Thank you. Another question. Is there a method that you recommend for someone who wants a steady cycle with not too many ups and downs?
Yeah. So anything that has that longer, the less you have to do it, the steadier your cycle is going to be. So if you're really concerned about ovulation, those IUDs may or may not do it for you because everyone is different. Mirena IUDs are so often really well tolerated and people are very happy with them. So if you think that's something you might want, you could try and see if you have ovulation suppression on an IUD. The Nexplanon gets you super, super long, steady ovulation suppression. And then otherwise, you could consider the Depo shot, super steady, super consistent. And then the NuvaRing can be really good too. And especially if you use it more continuously instead of having that withdrawal week in between, you can create a pretty steady state too.
Does your answer change at all if it's a teenager?
No.
And and then can birth control affect future fertility?
The only one I would really worry about is Depo, and only in that it takes it can take some time for you to go back to fertility. And so if you're young and you like Depo, and a lot of people actually, the Depo is very polarizing. You either love it or you hate it, and that's okay. But if you're 16 and you love your Depo, that's great. Stay on your Depo. And if you think, when I'm 25, I want to start trying to get pregnant, then I would say maybe when you're 24, let's stop your Depo. For most other methods, I would just say, like stop the month before and go at it. But none of these methods, other than getting your tubes tied, have like a known chance of injuring your fertility. IUDs, if you have a complication, like a serious complication that's really, really rare, could have some impact on your uterus, because that's where, like, if you need to have surgery on your uterus, that may have an impact. As someone who takes care of IUD complications, the large majority of IUD complications have no impact on future fertility.
And I know we're at time, so I'll finish off with one last question. If someone has lupus, could there be any contraindications about taking the pill with estrogen?
Yes, definitely. Lupus is, I would definitely say, is a complex medical condition. And so you should have like a really tailored conversation with your doctor. Some flavors of lupus that are a little bit less severe, you might be able to do estrogen. And we would have to kind of look at your whole picture and weigh some risks and benefits. But if you were a test question, I would say that because you have an elevated risk of clot, I would not recommend estrogen.
All right. Well, thank you so much, Dr. Ferguson, for sharing all that great information. Thank you, everyone, for joining, and I hope everyone has a great rest of their Friday.
Great. Thank you so much.
All right.